work on the house instead of go to the harvest card. You could change my mind.
Yeah,
Well, here we are,
Ready, set, go.
right? So you know what, while we're thinking about this, I'm wondering, I'm just watching my stream right now, and it is pretty good. We do see the screen. But what if we move, is your phone gonna die?
No, I've got it plugged in. Otherwise, it would be dead by now.
I mean, I will put it right back here, but are we gonna get a better view from here?
It'll be like a seat.
Let me see what it
I don't
looks
know.
like. Hold on, I got it. One second, don't move, yeah, don't move it too much.
Oh, I'm not gonna move it.
Alright,
Outside biotech
okay.
position, like right now.
Hold on, it takes a minute to change. Do you have it on pause?
No?
Alright, hold on.
Okay.
same call. Later on, okay, so we go through screening protocol, go to the tree. As per the metro.
Is that better?
It's doing a,
Sticking around with it, grab this flash, push it, try to.
stop for a second. It says it's live, but it hasn't done the stroke yet. There's like a delay by about a minute. Yeah, but I moved it.
Oh,
And then you can move the side, I don't know this.
Sorry, I'm gonna be one more minute here.
And.
Come on.
Any luck on getting that list compiled for us yet?
Yes, so I have the, he gave me the final print today. So I'm gonna take a back print tomorrow. I'll just, yeah, he just gave me the, what do you call the, can't even think of what it is, the proof. So there's a couple of errors in it, and I just have to change them to take it back to them, and we should have printed by, I wanna say by the end of next week. So we'll see.
sticking on this thing.
Alright, but let's go on to
Is it?
asphalt stuff.
It's like, yeah,
For
click it.
AT&T.
Yeah, we can do
No,
that.
it's not that. Something's wrong with the program is going through very.
Thank you.
Well, for right now, it's not, did you pause it?
No. Because I can see it on here.
Maybe it's just my,
Go back to the link and see if it,
see if it's on.
no. Let me go upstairs and look at mine real quick.
No, it's not that. Why is it doing that?
Well, I don't know why it's doing this. It's like I've lost my internet, but I know I got my internet. Connected.
I've got it on upstairs.
I don't know, it's weird, huh? I know with the new update on the 360 and the whatever they're doing, sometimes it does some weird stuff on me. I've had to update the whole entire PowerPoint in the newest version. Yeah, I saw that somewhere.
So I need to save it as a different version?
Yeah, the newest version. So that, not my last one, I did that, and I had to do that. It wouldn't even play my videos either. Why is it not?
I would say we have already come to competition, especially in the.
It's playing it like it's.
I don't know. Right, so,
This is gonna work out great, but it didn't like that.
Save it as something else.
Just, no, save it as the same thing, but update it, unless you've got the latest version.
So save it as a PowerPoint version?
Yeah, save as, and then it'll say updated version or not, maybe you have updated version.
All I'm saying is K. I'm just saying K.
So, just hit the back button, Kurt.
Yeah? Hold on, let me do this real quick. Make a new. There we go.
I'll show you
And then,
how to get to it.
this guy.
You still having trouble here?
Yeah, it's clicking through like crazy.
Okay, well,
Doesn't matter.
that doesn't look bad. Does it?
Yeah, except that's not, well, it's streaming now.
It should be. It's like
Yeah.
a minute delay.
There's a little delay on it, yeah.
Well, let me see here, so which way do I wanna move then? Like this?
Well, where do you wanna go with it?
Well, I just wanna give him a wider berth so he can be seen, so like when he walks
You
out.
want it wider?
Yeah, I just want him to be able to see more, so he can walk back and forth.
Say hi to Captain Aldridge.
Well, okay, so come here and let me show you. So this is what I've got on the stream. I can make it this big.
Yeah, do that, make it big.
She's big.
Is that how big you want it?
Yeah, and then, let's see if I can level it out, right?
Okay, stop.
Yeah.
Problem is then you can't see the screen.
I take her every night.
Alright, bring it in a lot.
You take her on the day.
So,
Yeah, okay. She likes it.
okay, now go take a look. It might be back just a little bit.
So just, yeah, what do I got?
Okay, give it just a second.
No, 2 weeks ago?
That's nice, yeah. Yes.
You want it closer than that?
No, that's good.
Zoomed in closer?
No,
Is that okay?
Yeah, that's good.
Okay,
Let's try that. Let's see if that's better.
just trying to make you happy.
No, let's see if it's better.
Okay. All right. to sit in class?
Yeah.
Okay, you guys ready? Okay, so now we're gonna review stroke, okay? I apologize, the PowerPoint is doing goofy things and I don't know why it's doing goofy things. So, what is a stroke?
It can be either hemorrhagic or ischemic, so either blocking, like a clot blocking,
Mhm.
or it can be a burst vessel.
Okay, and so what does that do to the brain? What are we talking about? Lack of perfusion, good. So that leads to what? Death, right? Okay, so it's kind of a similar process as to what's happening in the heart with an MI, right? If we're having an ischemic stroke, it's kind of the same thing, right? We're going to get ischemia, then the brain tissue is going to get injured, then it's going to die, right? Okay? And there's the two processes, either ischemia or hemorrhagic, right? Okay. Okay, so what are some signs and symptoms? What's our classic? One-sided weakness, right? So left or right. What side seems to be more prevalent? Now, my practice, it seems like it's more left-sided than right, but I don't know if that's true or not. Okay, so one-sided weakness, difficulty speaking, headache, right? This is going to get old quick.
You want me just to push the button?
But it still does it even when you push the button. Okay, so what are some other ones that you guys have seen or?
Turn mine?
No, it's not this. It's the computer because it does it
Okay.
even when you're on, even with the mouse it does it. Okay. So what are some other signs and symptoms besides our classic one-sided weakness, speech, headache? Okay, blood pressure is going to most likely be high. What else? What about, like, think about your other signs and symptoms of a patient. What's their skin color going to be like? Could be normal, right? They could even be flushed if they're have hypertension, right? What about the respirations? Could be elevated because of anxiety, right? Okay, so they may be anxious. Depending on the severity of the stroke, they could actually have respiratory changes with it, which we'll talk about when we get into the pressures in the head. So yeah, so you might see those things. Let's see if how do we talk to our patient? Nausea, vomiting, seizure. So seizures is another big one. If you think about it, if you've got a part of your brain that's ischemic or it's dying, is there a likelihood that your patient could have a seizure as a result? Kind of makes sense, right? So seizure may be another sign or symptom, okay? All right, so how do we communicate with our patients when they're having a stroke? Can they understand you? Yeah, a lot of times they understand what's going on, right? You can look at them, and a lot of times what I'm looking at is their eyes, right? If you look at a patient's eyes, that tells you a lot about how well they're mentating, right? If they're making eye contact with you, you can tell when somebody's processing information, right? You can tell those times when they're completely out of it. So you can look at your stroke patient, and you can probably tell whether or not they are actually understanding what you're saying, even if they can't respond to you, right? But there may be times when they can't respond to you or are not obviously processing information, right? So they may not be able to speak at all. Okay, so there's two different terms there. So what is difficulty speaking?
Saying a couple words at a time.
Right, so yeah, they may be only able to say a few words. They may not be able to complete a sentence, right? So when we do our assessments, what are we looking for with the speech? What do we typically look for? Slurred speech, right? We're typically looking for slurred speech, but there's another presentation. They may not be slurred, but they may not be able to find words. So they're trying to talk to you, but they can't make a complete sentence because they can't find the word that they want, even though their speech isn't slurred, okay? So there's the term dysphagia, which means difficulty speaking, and then aphasia, which means no speech at all, right? Okay. All right. I want to make sure I didn't miss one just now. Okay, we did that. Okay, so what's a TIA? Transient ischemic attack. What does the word transient mean? Comes and goes, right? Okay. So the definition is that they have stroke-like symptoms, but those symptoms resolve within 24 hours, right? So for us at EMS, are we going to know whether it's a stroke or a TIA? No. How are we going to treat it? Like a stroke, right? We always operate on worst case scenario, right? So we're going to operate worst case scenario, it's a stroke. We're going to treat our patients like it's a stroke, even if they have a history of TIAs, right? So you may have family members of the patient themselves saying, yeah, I have a history of TIAs, but they always clear up. There's no guarantee that this time it's going to clear up, right? So we still want to treat it like it's a stroke, right? So they're throwing little clots, they cause a blockage, they get ischemic, but then that blockage clears and they get blood flow returned, right?
So that's kind of like an angina.
Exactly.
Heart attack, but.
Yep. Yep, exactly. Okay. So as we're assessing our patients, I don't want to talk about stroke scale yet, but as we're doing our initial assessment, what kind of things do we want to look for as far as vital signs and the like? What do you guys want to collect for your assessments?
Get your baseline.
Okay, but as far as baseline, what do you want to capture?
You want to capture BP.
Okay, I want to get a BP.
Quality, strength.
Okay.
Respirations.
Respirations,
SpO2.
pulse.
SpO2,
Want to get an
blood
SpO2.
sugar.
I want to get a blood sugar. Okay, that's really important. Why? Why is a blood sugar important with this?
Sugar's toxic. Sugar's toxic.
Okay, so if they're having an ischemic stroke, I don't want to give them D50 because that's necrotic to brain tissue, right? But the problem is if my patient's having a low blood sugar event, could that mimic a stroke?
Yeah.
Absolutely, okay? So that's another reason we want to do a blood sugar is because potentially what we think is a stroke is really a low blood sugar event. So we want to get a blood sugar for sure, okay?
So what's the blood sugar gonna tell you if it's high? Is that gonna be more?
If it's high, then you're looking at DKA, right? Diabetic ketoacidosis, right? With that, if they're presenting with stroke symptoms, it may be they're having a legit stroke, right? We're going to report those signs and symptoms of stroke plus the high blood sugar, right? So the hospital is going to have to determine, okay, are the signs and symptoms a result of the high blood sugar, or are they just going to have to treat them separately? Because it may be that they have a diabetic that is truly having a stroke, but at the time they started having their stroke, they were high, right? But if they're low, what do I do as an ADMT or a medic? I'm going to give them glucose, right? So the caveat is this, right? So D50 is necrotic to brain tissue if they're having an ischemic stroke, right? But if my patient has a documented low blood sugar, what do I want to do? Do I want to correct it or not? Yes. I still want to correct it, okay? So what I want to do is I want to be judicious with it. I want to be careful with it. So that means I'm probably, standard practice now pretty much for all medics out there to just give a half amp of D50 anyways and give it slowly and dilute it as you're giving it, right? So you're going to have your IV running, you're pushing it slow, so that you're kind of diluting it and you're not shooting your patient way high on their blood sugars, right? But we want to get our patients back to a normal range. We don't want to shoot them up over the 200s if we can help it. Keep them in a normal range and then reassess their symptoms, right? Because their symptoms may resolve, okay? And if they resolve, then we know it was just a blood sugar event. If they don't resolve, they're having a stroke, right? Okay. All right. Next thing we want to look at when we're doing vitals is capture pupils, right? We want to look at pupils. What can happen to pupils if a patient's having a stroke? They could be unequal, right? We could have pupillary changes. They could be sluggish. They could be non-reactive. They could be unequal, right? Depends on what's going on with the patient. but pupils are another important thing to capture while you're doing your patient assessment. Okay, so let's talk about the Cincinnati. Just gonna skip forward when we get back there. So what do we assess with the Cincinnati? Facial droop, arm droop. Now, grip strength isn't part of the Cincinnati technically, okay? So it's facial droop, drift, and then speech, okay? Are they slurring their speech, okay? Come on. Okay, so how do we assess for facial droop?
Smile.
Ask them to smile, and what happens?
One side doesn't flip.
One side goes up, the other doesn't, right? So as we look at this lady, she can move her right side because we can see the wrinkles, right, forming, and her eyes kind of crinkling a little bit, but what's happening on the left side? Nothing, right? Okay, so that's facial droop. So one side of the face is moving, the other side is not, okay? Oh my gosh, this is getting old. Okay, what's the next thing we do? Okay, hold your arms up, and how do we want them to hold them up? Palms up, right? So we want them to be palms up, shoulder level, and close our eyes, right? And then what do we wait for? One's drift, right? One starts to drop, kind of drift off to the side, might do this, right? So they're trying to control it, but they can't fully control it, right? Or it may just fluff, right? Okay, so how long do we wait? 10 seconds, right? Okay, so hold them up there, eyes closed, hold them there for 10 seconds and watch them, okay?
Is there a specific reason why we do palms up?
I can't know. I'm sure there is. I don't know the reason. Okay?
That's what he would do.
Yeah. Okay, the next thing we assess is speech. So we ask them to say something, right? What's the typical sentence that you see in all the textbooks? You can't teach an old dog new tricks, right? You can't teach an old dog new tricks. So what are we watching for?
Well, if they're speaking in full sentences, or if they're saying a couple words at a time and
Yeah.
stopping.
Is it slurred? Are they able to repeat all the words? Are they dropping words, right? A lot of times I watch their mouth, so if you look at this guy, his mouth's kind of open and his tongue's kind of doing funky things. You'll see that with stroke patients where it's almost like they kind of control their tongue, like their tongue's going all over the place, doing weird things, right? Okay. So is it slurred, or is it garbled, or are they missing words? Okay. So when we talk about the Cincinnati Stroke Scale, how many of those have to be positive before we say it's a positive stroke scale? One, right? Only one of those has to be positive for us to say it's a stroke. Okay. Now your book talks about your textbook, not necessarily the AHA book, but your textbook talks about the LA Stroke Scale as well, right? Here in the Valley, pretty much everybody uses Cincinnati. I'm not aware of anybody that uses LA. Isn't 2B just Cincinnati? It's not LA, right?
No,
LA is much more in depth, and it's much more accurate. So according to your textbook, the Cincinnati has a 72% probability. The LA, I think, said 92 or 96. It was in the 90s. Okay. All right. So those are your assessment points, right? You're going to go in, you're going to look at your patient overall. What's their level of consciousness, right? You're going to capture your vital signs, including a blood sugar and pupils, okay? And you're going to do your stroke scale, okay? Now, what kind of patients do you guys think you want to do a stroke scale on for Cincinnati? I would say anybody that's altered for any reason, okay? If they seem even the least bit confused, I'm going to do a stroke scale on them, right? So if it's somebody that's maybe a diabetic, maybe a seizure patient, maybe an overdose, whatever, if they've got an altered LC, I'm still going to do a stroke scale on them because I want to know they have a deficit, right? All right, so with strokes, we can have increased intracranial pressure, okay, whether it's ischemic or whether it's hemorrhagic. Now, obviously, if it's hemorrhagic, what does that mean? Hemorrhagic means what's happening in the head. Yeah, there's a vessel that's burst and it's actually bleeding into the brain, right? That's hemorrhagic. Okay? Why could you potentially have increased intracranial pressure with a ischemic stroke?
Inflammation.
Very good. What happens with inflammation? Swelling. So what happens to the pressure in the head when the brain starts to swell? Goes up, right? So yeah, you can have increased intracranial pressure because of the inflammatory response of the tissues swelling. The brain is lacking oxygen, it's starting to die, it's undergoing injury. You're going to have the inflammatory response, the tissues are going to swell, and the brain will do it too. Now, when we talk about increased intracranial pressure, for us in EMS, we can't really tell what's really causing the signs and symptoms. It could be a bleed, it could be because of a ischemic stroke, it could be because of a head injury, right? So there's a lot of different things that can cause increased intracranial pressure, but the presentation is going to be pretty much the same. As pressures go up, you're going to see the same presentations, okay? All right. Okay, so in relation to the body, how big is the brain? Not very, right? It actually makes up about 2 to 3% of your body weight. How much of your cardiac output does the brain get?
A lot.
20%. 20 to 25% of your cardiac output is going to your brain. What does that tell you about the demand of the brain for oxygen and nutrients? Extremely high, right? What happens when you cut off blood flow to the brain? How long can you stay conscious? Seconds, right? It takes seconds before you pass out. That's how fast the brain is processing sugar and oxygen. As soon as it loses that blood flow, bam, you're out, right? That's the demand. It's huge demand, okay? It gets it through 4 arteries, your 2 carotids, your internal carotids, and then there's 2 that go up your vertebrae, up your spinal column. So there's 4 that go up to the brain, and they all meet. It's what's called the circle of Willis, right? And it's kind of like a water distribution center system in the ground. So if I shut off one of them, I still get circulation through that circle of Willis because they're all connected. So just like a water system in the ground, if I shut off one valve, I can redirect that flow through other pipes, right? Because I've got 4 pipes going to my brain, and they all meet in the circle of Willis, okay? Okay, so we talked about it. Any interruption, you're going to have mental status changes and vital sign changes, right? If you have complete interruption, you're going to pass out, and your brain's going to die in 4 to 6 minutes, right? Or start to die in 4 to 6 minutes. In 10 minutes, you're really dead. Okay. Okay. So the brain needs all this blood flow, right? What kind of a structure does the brain sit in?
Hard shell.
A hard shell, right? Does it have any give? No, doesn't have any give, right? So it sits in this rigid vault, the cranial vault. It's not going to move, right? So as the pressure increases, what happens to the brain? It gets squeezed, right? And eventually, as the pressure gets so bad, it starts to herniate, right? Millimeters of mercury of pressure in my head. How much pressure does the body have to generate to get blood up there? At least 81, right? To get blood to go into the brain. It's a pressure gradient. If I have less pressure than the pressure in my head, the blood is not going to get up there. Okay? Okay, so let's skip that. Okay, so if we look at this, and this is kind of a gee whiz thing for when we talk about head injuries, if you guys ever get into your head injury lecture. The black line is under normal conditions. Under normal conditions, the brain can control the amount of blood it's getting by controlling the diameter of the arteries. So if it needs more blood flow, it relaxes those smooth muscles and allows the arteries to dilate, more blood flow, right? If it doesn't need much blood flow, it constricts them to reduce the blood flow. And that's under the normal. If it's not injured, if it's just fine, it's under normal pressure ranges, it's just good. If your patient's undergoing injury, if they've had a traumatic brain injury or anything like that, that goes out the window. the brain can't control the diameter of the vessels anymore, and it becomes this linear relation, okay? As pressure goes up in the head, pressure goes up in the body to match, okay? So if we look at this, okay. Back up here. I'm gonna skip that, okay? As pressure goes up in your head, what does the body have to do? It has to increase pressure. So pressure goes up in the head, pressure has to go up in the body to overcome it. But what does that do to the pressure in your head? Increases it. So what happens to the pressure in the body? It has to go up to overcome it. What does that do to the pressure in your head? It goes up. It becomes this vicious cycle of increasing pressures. That's why when your patients have either head injuries or bleeds from other, like hemorrhagic stroke, or enough inflammation and swelling that pressures are going up, you'll start to see pressures that go, start at 120 over 80, they go 140 over 90 to 160 over 100 to 180 over 2, or 180 over 110, 120, 200 over 110, 220 over 150. They just keep climbing. And that's why, because as the pressure goes up in the head, the body goes up to match. Okay? Okay. So some signs and symptoms that you may see as pressures go up in the head. And again, it doesn't matter why the pressure is going up. It may be a stroke, it may be a traumatic brain injury, it may be an overdose, whatever it is that's causing the pressure to go up in the head. Okay? So you'll see respiratory changes. So some typical ones. This is the one I've seen the most, but Chain Stokes is pretty interesting. It's one where the patients will breathe really shallow and then deep and then shallow again and they go apneic. So you'll be watching your patient and they're not breathing and then they'll start to breathe really shallow and fast. They'll be, and then deeper, and then shallow again, and then go apneic. And then repeat that. And they'll keep doing that. It's funky to watch, right? The one that I've seen most often with patients that have severe traumatic head injuries or severe strokes is central neurogenic, which means very deep and very rapid. It's almost forceful. So it's like this. They breathe like that, okay? Ataxic just means there's no rhyme or reason to it. It's just really irregular, right, is ataxic. Your patients may also posture, okay? So you guys know what posturing looks like? I've got a slide here. We'll catch that here in a second. Oh, you piece of crap! Man, I'm tired of this.
Sorry,
Why?
I
What's
looked
it
it up
doing?
on what's doing it. It says it's a malfunction with hardware.
Awesome.
Right there.
Oh, okay, we skipped this slide here.
No, we just redid it last year.
Okay.
I had to approve the budget with her on that one.
Okay. So one thing with your vital signs, okay?
Way to go, I'm proud of you.
With head injuries, with strokes, you can have what's called a Cushing's reflex. That is where, as the pressures go up in the head, what's going to happen to the blood pressure again? Going to go up. Okay. What's going to happen to the pulse? It's actually going to drop. Okay? Because as the pressure in the head goes up, the brain actually starts to get pushed down. It'll actually start to put pressure on one of the cranial nerves called the vagus nerve, the cranial nerve 10. Your vagus nerve is part of the parasympathetic system. So when it's firing, it's telling everything to slow down. And that vagus nerve actually goes to your SA node in your heart. So what happens to your heart rate? Goes down because of the pressure in the head. So as your patients, as the pressure goes up, you expect to see blood pressures going up, you expect to see pulses going down, and you expect to see respiratory changes, whether it's that chain stoking, whether it's very rapid central neurogenic, or whether it's ataxic respirations, right? So changes in blood pressure, pulse, and respiration is Cushing reflex. Blood pressure going up, pulse going down, respiratory changes, okay? You would also expect to see altered mental status. So your patients aren't going to be a Glasgow 15 most likely, right? They're going to start to drop in their LOC. And then you'll start to see, as pressures continue to increase, you're going to start to see pupillary changes. Because the nerve that actually controls the size of your pupils runs right underneath the brain, like right here. and as the brain gets pushed down, it pushes on that nerve, paralyzes it. And then that pupil just goes, whoop, dilates, relax, okay? So when you see dilated pupils, if one's dilated and the other's still normal, that tells you the pressure's on that side. So whatever side is dilated, that's where the pressure is. Now as the pressures continue to go up, eventually the other side's gonna have enough pressure that it's gonna move down too, and both pupils will dilate, okay? I'm just gonna leave it like that on in case you can see. Okay, got that, talked about that. Okay. Okay, some other general symptoms that you'll see with increasing cranial pressure. Loss of consciousness, confusion, repetitive statements or questions. Have you guys seen that before with your patients? Right, you get that head injury, and what do? What happened? Where am I? Right? And your stroke patients can do this as well. It's not as likely as it is with head injuries, okay? Now the other thing is be careful of just repetitive statements. So a lot of times you hear the patient will have repetitive questioning, but repetitive statements are as bad. So I've had patients like, especially post-ictal patients, that'll be like, hey, can you tell me your name? I'm fine. Can you tell me where you're at? I'm fine. Can you tell me what happened? I'm fine. Is that patient fine? No, that patient's not fine, right? Okay. All right. They may have pain. They may have dizziness. They may have projectile vomiting, right? You guys have seen that before with head injury patients. They just vomit like a garden hose, right? They may be combative. They may have a seizure, and they may posture, and they may have signs of paralysis.
What's posturing?
We'll get to it in just 1 sec. I've got a slide. Here's your pupillary changes, right? One pupil's blown, the other one's not. Okay. Now the fact that this guy, to me, looks like he's conscious, right? This may be blown because of some other reason, right? So, I don't know. I would expect somebody that truly has a blown pupil to be decreasing their LOC, right? Due to pressures. Okay, so this is posturing, right? As pressures go up in the head and the brainstem starts to herniate, which means it's getting pushed out the bottom of the skull, out through the foramen magnum, right? The patient will start to posture. So the first one is called decorticate, right? Where if you do a sternal rub on them, you give them a painful stimulus, they'll respond by flexing, right? So flexion or decorticate posturing is the first one you'll see. That, and the way you remember it is that decorticate is they're holding on to the core, so therefore they're holding on to life, right? When they go decerebrate, so that means they're extending, you give them a painful stimulus, and they do this, they rotate out, and they extend, and they point their toes. That's called decerebrate. That means they've let go of the core, they've let go of life, they're dying. So decorticate, decerebrate. Okay. Any questions on that? And you could potentially have a stroke patient that presents like this. Okay. Oh, the other thing is, you can have seizure patients present like this. You can also have diabetics present like this. First time I ever saw a diabetic posture, it freaked me out, right? We go in, it's a known diabetic. We're doing vital signs. I want to see what her LOC is, so I give her a good sternal rub, and she does this and postures. And I went, she's got a head injury. That's what I thought posturing was related to. I'd always learned posturing is a result of a head injury, right? Freaked me out. We continued our assessment, got a blood sugar, she was low. So what do? We corrected the blood sugar, right? We corrected the low blood sugar, even though it's D50 is contraindicated with head injuries or bleeds, because D50 is necrotic to brain tissue. It's necrotic to all tissues. Yeah, it's all tissues. But corrected it, she came around, she's fine, right? Class scale 15, not posturing, no head injuries. So just recognize that pretty much anything that causes a neurologic change could potentially cause your patient to posture. Seizure patients, diabetics, head injuries, strokes, could potentially function, okay? It just really freaked me out the first time I saw it. But I saw it several times after that with other patients as well. Okay. So, if we're going to maintain an airway on our patient, if your patient is conscious and can maintain an airway, what do we want to do? Give them some O's, right? Because we want to increase the O2 content in the blood. Hopefully we can get more blood past that blockage if it's an ischemic stroke, and get the tissues better perfused, right? So we're going to put them on O's. We're going to transport them, and what else are we going to do as far as treatment goes? What do the hospitals want on stroke patients? Okay, as we're going in, we're going to get a weight. Okay, but as far as our interventions, what else are we got? IV access. What kind of IV access? Large bore and bilateral. Okay, hospitals, if you're calling it a stroke and this patient's going to end up in the CT scanner and potentially surgery, or they're going to get the TPA, the fibrinolytics, they want 2 large bore IVs, bilateral large bore IVs. Okay? All right. Now, what if your patient's unconscious? Let's say they're unconscious and they're not controlling their airway. Did I go backwards?
It's an airway device.
Now, this is really getting old. Okay, there we go. Okay, so we're going to have to ventilate them, right? So if they're unconscious and they're not maintaining their own airway, we're going to have to control the airway, and we're probably going to end up ventilating them at some point, right? If they're not maintaining their airway. So what are we going to use? Potentially, if they don't have a gag reflex, right? We could use an LMA, right? Okay, what if they still have a gag reflex? We put an MPA in, right? Throw an MPA in. Positioning as well, right? Head tilt, chin lift, right? MPA. Okay. Let's say the respirations are really slow and erratic. They're not, so they have those ataxic respirations, irregular. They're not satting well. It's obvious the ventilations are not adequate, right? We're going to use a bag valve mask, right? Okay. So, what rate do we want to ventilate at?
Every 5 to 6 seconds.
Every 5 to 6 seconds, which is how often per minute? 10, okay? So let's shoot for 10, right? Okay, so we're going to shoot for 10 on an adult. Okay. How many of you guys, you older guys might have heard, what did they used to tell us for ventilation with head injuries? If there were signs that the patient had increased cranial pressure, how did they tell us to ventilate the patient? Do you guys remember? They used to teach us to hyperventilate them, okay? They used to tell us to hyperventilate them because when you hyperventilate a patient, you blow off CO2, right? So if you're bagging a patient rapidly, you're blowing off CO2. When you blow off CO2, the arteries respond by constricting, right? So if I can constrict the blood flow, the arteries, and reduce the blood flow to the brain, what am I doing to the pressures? I'm going to drop them, right? I'm going to drop those pressures. Is that a good thing when we talk about head injuries or bleeds in the head where it's causing pressure? Yes. Yeah, sounds good on the surface, right? What was happening in practice?
Gastric distension.
No.
You're not getting enough perfusion up there.
Exactly. So what they were finding was patients who had bleeds in their head and were hyperventilated were having anoxic brain injuries because we were reducing the blood flow to the brain and they weren't getting any oxygen up to the brain. So they may have had a bleed, they may have had a stroke, but because of the pressures, they're saying hyperventilate them, that'll reduce the pressures in their head. Yes, it does, but it's reducing the blood flow, so you're reducing the oxygen. So their outcomes were worse because of the hyperventilation, okay? So, if we're ventilating a patient, whether it's a stroke patient or whether it's somebody that has increased cranial pressures because of a bleed or whatever, we want to maintain ventilations at 10 per minute. If it's an adult, 20 for a child or 25 for an infant, okay? If we have capnography on our patient, we wanna keep them in that normal 35 to 40 range. So if you've got that cannula on, a capnography cannula, and you're ventilating your patient with a BVM, which you can do, you wanna keep that in the 35 to 40 range, okay? Now, if you start to see signs of herniation, so what are those signs? Pupillary changes, or posturing. If you're seeing those signs and symptoms of herniation, they say you can start to hyperventilate and try to reduce pressure, but that's only if you have capnography, okay? So if you have capnography on your patient, you can ventilate them a little bit faster to drop their capnography to the 30 to 35 range. So just a little bit lower than normal.
So they find if we stick within that 30-35 that we're not.
You know, we're not reducing the blood flow to where we're gonna be causing an oxygen. Okay?
And what that looks like is high into normal, so like.
12 or 15.
Right around 20, yeah, I mean, 20 would be the highest end you'd wanna go.
Yeah.
So, and we wouldn't wanna use hyperventilate anymore, we'd call it, we just ventilate a high end of normal. Make sense?
And our capnography is pretty responsive.
Yeah.
Yes,
It's
you'll see the
very
numbers
responsive.
right
It's really
on there
easy to
working.
adjust.
Yep, those numbers change pretty rapidly.
I love capnography because I don't have to guess if they're dead anymore. It's like the best numbers in the world. You can see if it's 10, they're dead. And it's stayed at 10 for a long time, or it's gone down to 8. It just takes away all my guesswork and wipes my conscience clean.
Okay. Okay, so transport your patients. Where are we gonna take them? Stroke center. Okay, what the hell does that mean?
Not a stroke care.
Not a stroke receiving
No
center,
stroke receiving. Yes.
right? You guys heard that term out there?
Yeah.
Yes.
Okay, so what's the difference between a stroke center and a stroke receiving center?
One can recognize it, one can treat it.
Okay, so a stroke receiving is going to do a in-depth assessment, and then what are they gonna do when they say, yeah, it's a stroke?
Transport them to a stroke
Transport them,
center.
right, to a stroke center. So, as being a patient advocate, where's a better place to take them? Stroke center, straight up every time, right? Okay, so who's the stroke centers? IMC and the U, right? Okay,
And St. Mark's now.
St. Mark's is now?
Yeah.
Cause they were
That's
all.
not consistent with the memo that just came out a little while ago. The memo that came out a little while ago does not read that way.
So
It said
which
Mountain
one?
West, or not Mountain West, I'm sorry, Jordan Valley West.
Did they get
Yeah.
certified
and
as a stroke
Jordan
center?
Valley South.
Yeah, they just barely did get theirs.
Okay, so then that's new.
Don't tell me that's wrong, because we sent somebody that 3 days ago.
No, you're right, you're right.
Dude, I'm days now, so I miss all this stuff. All this stuff goes, right? So yeah, so maybe Jordan Valleys, both Jordan Valleys, so
Yeah,
Jordan
they
Valley
just
West.
they barely came out, I think, I wanna say 4 to 6 months ago.
And they're not receiving centers, they are true
They're
stroke
full on
centers.
stroke
Okay.
center, that's.
Well, that's good.
That out, right?
Yep.
That's good to
Yep.
hear. Okay.
Good to go on that.
So, they have to have a CT scanner, right? Because otherwise you don't know whether it's ischemic or whether it's hemorrhagic. If it's ischemic, what is our guidelines, for TBA? What's for fibrinolytics? I can't say that word.
I can never say it.
I can't, fibrinolytics, there we go. Fibrinolytics, TPA. What's the time frame?
3 hours.
3 hours. Okay, so apparently, according to your guys' textbook, there's now some meds that are out good out to 4.5 hours. So 3 to 4.5 hours. But what is that measured from?
When it happened.
Onset, right? When did this patient have the onset? So you go there in the middle of the night and they've been asleep. What does that problem does that present for us?
So is it your last seen normal time?
Yeah, last seen normal time, which may have been at 8 o'clock in the evening when they family members last saw them, right? And now it's 3 o'clock in the morning, right? So now we're outside of our time frame because we don't know when that onset was, right? We have to report that to the hospital. We have to tell them, okay, onset was this time if we know for sure, or we don't know what the onset was. Last seen normal at this time. Okay? And that's because there's that time frame if it's an ischemic stroke of when they can give the TPA. Right? Now, if it's hemorrhagic, based on the CT scan, what are they gonna do? They gotta go in and drill a hole in their head. Yeah, they gotta do surgery, right? Yeah. And that's kind of the big stumbling block for most hospitals to be able to get stroke center certification, is they gotta have a neurologist on call that can go in and do surgery 24/7, right? Okay, so we just talked about determine and document exact onset of time symptoms, and document the information of the person you got that information. So if it was the last seen normal time from a family member or a friend, make sure that you document who you talked to. Husband, wife, brother, sister, or whatever it was, right? Okay. Let me make sure I didn't miss anything in there. Because it was skipping everything. Okay. I think we're good. Okay, any questions, you guys? All right, let's take 10 minutes and then we'll do some hands-on with the monitor, and then we'll do some stroke scale stuff and practice. Okay? Last time I was down here, it wasn't doing that.
Well, you wanna try mine? Maybe it's sticking, I don't know.
That's what I thought. I thought maybe it was the button sticking.
You might have to switch out the battery. My battery's dead on it, looks like. Apparently I left it.
High-tech, living.
I was wondering what those were for.
Now you know. They have
Nope.
to be just right.
It's not this thing.
They can be the full class.
Still doing it?
Yeah.
Yep.
I'm sorry.
What is mine after?
Don't you start sticking them without figuring out.
I'll come down and play with it. I'll put another thumb drive in. Yeah. You know what? Let me run up and grab one of my thumb drives real quick. Throw it in.
What are you doing up to, Cunningham?
Say that again?
What are you doing up to?
Just being Dave, man. What about you?
You're not gonna get in soon.
Are you, you're still at 117, right?
Yep.
Are you on the ladder or the engine?
Ladder.
Stillers are pretty nice, huh?
Yeah, they're really nice.
I heard it wasn't doing it with this version.
wonder if you have a corrupt thumb drive or something.
No, I think what happened is I think that this particular one got saved, like it was trying to play it. I think the program thinks that this is supposed to play, so when I click on it, it plays the slide instead of waiting for the next click. So I've got it on click, but it says duration is auto. So I think what happened is it says, oh, I'm going to play it, and it's kind of slow it down or stop. If you look up here, see how it's playing?
Yeah.
The other one, my other one was this one. When you would go to the slideshow, right here, if I click through it, oh, there's a button, but it's not kicking over. Okay. So it would allow the animation. So I'm thinking there's something wrong with that particular one. Because this one's looking fine.
Okay.
It's this other one. I think it's something to do with this right here. See how it's duration.
Yeah.
That. Now it's actually good. I think that's what it was.
Okay. All right.
Nope. Same thing.
Nope.
Yep.
Okay.
So I think that that's the issue. I don't know how to fix that.
Right.
New to me, something new for me to learn.
So the IT guys need to.
So they're all in order.
There's a.
Where are you gonna be so we can,
I just don't think I'm gonna up on the table and make a just gather around.
okay. Okay.
Madison, did you get that tattoo all done?
I just have to do the color now.
My sister used to do tattoos at Big Bucks.
Oh, really? That's where I go? That's awesome.
I noticed on the gram, I saw her.
Oh, yes. Gotcha, gotcha. Well, that's cool. Does she still do it, or what does she?
She does. She has like her private.
Oh. Oh, that's nice.
I think.
Yeah.
Yeah. Well, I should know.
That's all right. I don't know too much about my brother either. So
What's
I'm
that?
okay. I think it's fair.
It's just how it is.
Yeah, exactly.
Well, it's still streaming,
Oh.
so is there still gonna be stuff that they'll wanna see streaming?
Oh, where's the camera? Oh, we might just have to point it. It's
Okay.
kind of hard because it's gonna be hands-on stuff. So.
Yeah.
Well, we can try.
I'll be honest with you, John, after a presentation part, like practical stuff like this, I would watch if I was watching.
Really? Okay.
That's just me, that's one person.
Everybody
Okay.
good?
Kelly's gone, he had to go pick up his son.
Oh, okay. So we are all back then?
Yep.
Okay. Okay, if you're still watching on the stream, we're gonna shut it off because we're gonna go to some skills here and you won't be able to watch. So, sorry, we're gonna shut it off. Is that okay with you? Okay.
Okay, guys, you guys ready? Why don't you guys gather around up here?
Does it
We'll go
show
over a
on
few
yours now?
things on the monitor. Hey, John?
Yep.
Never mind. There's a roll in here, but I'm using the spare roll that's in there.
Okay.
Okay.